It's interesting listening to the last talk and listening to a lot of people around here. I mean, this is an industry and a group of people that are very comfortable with high levels of relevant retrieval and text and all the stuff that goes on here. I mean, I come from this business. I'm not as deep as some of you guys, but it's amazing. We took this technology into the healthcare business, and they were flabbergasted. It can do that. It works. In fact, you see one of the slides. I actually, when I get up in front of a crowd that's part of the healthcare business, I actually say, and it works. Two examples. One of our first installations, one of the marketing people did a video on what our product did, a live video, and you won't see the video, but you'll see some of the results of it. And in describing our technology, this is a technology that's near and dear to all of our hearts. It helps better our products. It helps better, the contributors to our product. And he referred to to the action that our product took as automagically. Right? So he referred to, and automagically you get this. So that was another one. And then so our next installation, which actually was last year when I was talking to Jabin, and the lead developer from Allscripts. This is a $2 billion a year company. They do stuff at a level that's beyond me in terms of the way they integrate, and they refer to our product and our technology as the psychic. This is the truth. In fact, we did a press release with them where we actually referred to it as the psychic. So I had to explain to people, it's not witchcraft, it's not black magic, it's not hocus pocus, it's the real deal here. This is what we do on an everyday basis. But for the healthcare industry, it's been pretty disruptive. It's been a real pleasure working in this business and saying, hey, this is what it does. So I'm going to try and get through. Margie explained it very quickly, so I go through this. We started in 2011. Our flagship product is called Medical Claims Compliance, which is really used for development and demonstrations. And I'll give you that demo, and you'll see how what you talked about here for the last and what you guys do on a daily basis. I'll show you live how it works. And it uses the Data Harmony suite of software. It's the same thing that we all talk about here. It comes from Access Innovations. Have you guys told them about the company? I guess you have, right? So we can blow by this real quick. You know when it started, the taxonomy. It's interesting. So we're in a business here. In this healthcare business, they have the taxonomy is done. It's baked in. It's over. It comes from the World Health Organization. It's referred to as ICD-9, International Classification of Diseases. I don't know, 15, 18, 20,000, whatever their taxonomy. They're going to a new taxonomy called ICD-10, which is 150,000 terms. But they didn't know they don't even know it's called taxonomy. They call it like classification, they call it diseases, they call it codes. And I will refer to taxonomy and go, wait, is that like stuffing an animal? And I said, no. So they don't get what the real deal is. So one of the nice parts is that's baked in. The bad part is we're dealing with medical records, patient encounters, providers talking into a dictaphone, medical scribe typing it, and it's definitely uncontrolled. I mean, it's all over the board in terms of what they can put into a medical record. So, and I touch on this because we use almost every single one of these within the technology that we ported into the healthcare business. So this is, we have the concept, the natural language, we have all this. So it's, and again, when I give this demonstration or this speech to, and I usually give this to technical people because we're doing an integration within their system, and I say, it works. And some people say, well, you're like, in this group, they'd say, of course it works. In that group, they'd say, how do you do that? And it really is. When we give demonstrations or we go into a provider, clinic or whatever it is, they say, how do you do that? Well, we try to get over that very quickly because it takes too much time to describe. So the technology, which we all know here, is spread all over, but you're starting to see, here's a medical one, here's a coder one. Athena Health, very, very big player in the, what they call the EMR space. Allscripts is up there. We've got some of the big boys lined up because this is now being integrated into, and we all know, I think you all know that it's a given fact that medical records are going to be digitized. It's at about an 82% compliance rate now. the federal government is investing a lot of money in getting providers to port over from the written word to the text, the digitized word. But they're doing it in a typical government way. They're giving them money, and if they don't do it, they penalize them. So, but that's where we're at right now, and about 85% compliance now, and within about 2 years, you will not be able to, actually I think, yeah, 17. So yeah, about 2 years, you will not be able to submit a Medicare or a Medicaid claim and get paid for it unless it's electronic. You have to have an electronic medical record. So now they can start, think about this. People used to submit claims, and the records were in the doctor's office in those file folders in the back room, and they'd pay the claim. Now they're saying, well, now you get to submit with the claim the actual encounter. You know, so they're starting to get tough on it. We took our technology, put it together. We have our company called Access Integrity, and we're starting to plant it places. We're getting that seed planted. And what I'm going to do now is do some live stuff so that we can actually look at, well, this is, so I'm going to give you some examples here. And it's fun to watch a technology that we all know about work in a field which, well, we thought it would work, but a lot of people say, well, what's it doing here? So you'll see how it works. So going live now, let me do this and pull this one up here. Okay, so this is our in-house version of what we install in these different environments. Like I said, they call them practice management platforms, they call them EMR solutions, but at the end of the day, there's these companies that provide the electronic technology services to the medical business, and we install this within that solution. So, all right. So what you're going to see basically, oh well, great. Okay. So this is a blank page. You know, you're going to have, this is your electronic medical record goes in here. So what you do, and again, in a real world, you'll actually go and you'll load up. Let's say we load up this cardiology visit. So electronically, it pulls it in. You open it up, and you'll see a different variety of this. But in fact, what it does, it pulls in the record, and it's always the danger in doing things live. So there we go. All right. So text. We all been talking about text, and again, it's pretty wild what people write in an environment where you can't capture a patient's problems, as they call them. But this is a pretty good one. I'll show you what we get back as feedback, because one of the things that was discussed here, when Dan was talking about it, Bob was talking about it, is that what do you do to make it better? And we'll get to that. You'll see that. So we look at this, and sure enough, up comes right away. So this is a selection of this is diseases. I would call it diseases. Really, it's diagnosis. This could be a diagnosis. So from this record, you can actually see it. We have the inline tagging. So you can actually then, the provider very quickly can take a note and say, oh, well, I didn't particularly want that. I can change it. So we're seeing at the beginning, and it's what they call clinical documentation, you can actually make it better. You can change this, and you can make that move one way or another. So this is diagnosis. This is a diagnosis of this particular encounter. This is for inpatient hospital. So if this was an inpatient hospital customer, this is how they would code this for that particular encounter. This is all the procedures that could go along with it. These are different codes that you put in. Again, it's the same thing I'm sure all of you do with whatever you're looking at. The recommender, you're looking at the suggestions. Now, we refer to this as highly relevant suggestions, because there is a community in the medical business, and they're coders. I mean, in this business, we may want to call them indexers, but the coders get their back up. They'll say, well, you can't auto-code. I said, we don't auto-code. What we do is we will give you suggestions. This is a suggestion for this encounter. And if you want to pick that, and you're going to see when I go to the next implementation that we have, you can do all sorts of things about whether they fit together. I mean, you can't have a 2-year-old boy type of child have a baby or have a hysterectomy. You know, they have checks on that. So we have what they call a code scrubber. But then you also have this new thing coming called ICD-10. So these are all the new. It's interesting. So talk about easy to sell when this thing comes, because it's been put off a couple times. But supposedly now, I had a call today, somebody said, I would bet my next week's paycheck on the fact that it's going to come through this year. But look at this. So you got the new codes. Look at those codes there. Ain't even close. Not even close. So there's about 25,000 of these codes. There's 150,000 of these codes. So it's you're talking about a little turmoil going on. People are panicky. So what will happen is, if the law goes through this year, and it's been postponed now 3 times, on October 1st, if you submit this claim on a claim number, you won't get paid. You have to, for a backache, you got to submit wherever it is down here, I don't know where it is, but you have to submit these numbers. You won't get paid. So that it's one. They don't have a burn-in period, or they don't have a kind of a grace period. You get paid one day, you don't get paid one day. So there's some turmoil coming. The other thing that's happened is with this whole new electronic medical record initiative, or push, whatever you want to call it. They have stages, and if you get through each stage and you do what you're supposed to do, you get a little rewards. It's called money rewards, and a provider will get it, a practice, a clinic, a hospital will get it. One of the things in stage 2 is you have to be able to tell the patient about what's going on with them in lay terms. You know, because the doctor will sit there and say, you got this, this, and this, and you'll say, oh, time out. What is that? So what happens is that they want to be able to, on the spot, during the encounter, to be able to say, okay, and this is an easy one because it's the backache, but let's say let's pick that, and what it does is it takes that code, which came from the record, and then populates that, which is not coming up, but it's a little slow, but hang on here. Oh, what happened? So, this is actually, oh, okay, Medline. Okay, it's Medline. So what Medline's done is they put together all these little vignettes, and this is for patients. I mean, this is not for a doc. It's not for a nurse practitioner. It's not for a PA physician. This is for the patient. So in this particular example, I don't know what's going on, herniated disc. But I tell you what, this is really flush with, you go in and you go to all, they have all sorts of, in fact, if you go into this, it'll show you all the different, you can actually become part of groups. You can, it's pretty cool. It's pretty neat. And there's dozens of these kinds of databases. I think Clur's got one, I'm sure Elsevier's got one, But the key here for us, because we don't want to get in this business, that's something I don't particularly want to get into. I know I don't want to get into it. The key is it all drives off of these codes. So once you come up with a good code, which guess where the code comes from? Right here. So you really got to write those rules tight. I mean, we write the rules all the time, and I'll show you how we really have an advantage in writing those rules in this business. So another time, somebody else came on and said, we had one of our focus groups, we have a group of doctors that we go out to dinner with. They always want to go to the expensive places, but it's cool. So you have statistics, and one of the administrators said, look, I have 6 locations throughout New Mexico, and what I'd like to do is I'd like to know what's going on in those locations every day. I said, well, how do you find out now? He says, I don't know until the end of the month when we send out the bills. In other words, the bills and the claim submissions to the payers, which are the Aetnas and the Blue Cross Blue Shields. I don't know. I said, well, you could find out right now what people are actually looking at within minutes. So in other words, whatever came from that note and the results of that note, you'll see these were the suggested diagnosis. These are actually what they were selecting. So this guy, and I said, well, okay, fine. So you know that there's a whole bunch of problems with people's tonsils in Las Vegas, not Nevada, but Las Vegas, New Mexico. He said, yeah, but you got to remember that clinic has a little pharmacy. And if I see something coming in that I can actually buy antibiotics or drugs for it, he says, I'll buy them and have them shipped up there, because guess what? We make money on that. Instead of sending them to CVS or Walgreens, sometimes the patient will say, nah, I just want to get it now. I'll buy it at your local little pharmacy you have here. So he said, I want to be able to stock that pharmacy based on what's coming in. So I said, fine. So that was just another user that was interested in being a little bit more exact about what's coming out of the results. So, let me go back here. I think that's it for here. So this is our product. This is what we do. And again, load this up. That's patient. This guy's playing basketball. I think this guy was a basketball player. Question? Yes?
Are you going to talk about the difference between the ICD-9 indexing and the ICD-10 indexing in terms of?
Not right now, because really what we've done is we've actually put it out there as a beta to get a sense of where we are, but we're really not in earnest going to really pound on it because it's a different treatment. Now we're going to still have the same, rule base.
Yeah, that's the part I don't quite get. It's the same rule base operating against two different.
Yeah. Okay. So here's an example.
So the rules.
For instance, there's an ICD-9. If you have a broken ankle, it's going to tell you what if it's a broken tibia, fibia, ankle, foot, or whatever, left, right. So that's got to be. While you want to go and identify it as a broken ankle, then you want to give them an option, and that's what we'll do. We'll have a tree that comes up and say, you want to do left, right, below the knee, above the knee, that kind of stuff. So it's a little bit more exact, but at the end of the day, we have to write new rules.
So in going from ICD-9 to ICD-10, is what's happened that it's become so detailed that you don't get the more meaningful general hits to this is a broken ankle?
You start there. Sometimes you'll start there and work your way to a tree. So in other words, you can have a broken ankle in, whatever happened to this person here, Pleasant 17, playing basketball. Result of striking against an object. So what happens is, let's see what happens here. I think this one's not working. I don't think we haven't worked on that one. But rule-based kind of question as far as ICD-10 goes, and from 9. It's we've started program.
What's that?
The question is about when we go from 9 to 10. What is going to be the.
I was just interested in in the details of the nature of the difference between ICD-9 and ICD-10, but it's too in-depth a topic for right now.
In short, ICD-10 is like 5 times as large. So
Yeah.
we're going to port over with thesaurus, using the term broadly here, it's just a bunch of codes. It's all of the words and what we actually see and understand from it is actually a subfield.
Yeah.
So what they've done is they've split the codes. So what we're doing when we port over to ICD-10 is that we're trying to take those codes, map them to ICD-10, and then use our existing rule base and then try to make it work.
So we have already made the simple rule base for ICD-10, and we have not finished the complex rule base for ICD-10.
Okay.
Is that accurate?
They would never trust me with that kind of information. And they're smart. They're really smart.
He's the customer.
Yeah. So I was talking about how we make it better, right? So one of the nice things about this business is that, I don't know about it in your particular examples or your particular environments, we get back every single day what they're writing about. This is the real deal. So what we can do is, we get hundreds and hundreds of these back. These are encounters that have been put into our system to be analyzed. So we can you walk through here, and it's the real deal. I keep repeating it, but this is really people that are coming in and having these things looked at. Now, what we can do then is because we can analyze it, we can see what we suggested, and we can see what they selected. So we first of all will look at the selection and say, were those good selections? Were they good? And you might say, well, maybe we could tweak it a little bit, make it better. But the pedal really, the rubber meets the road when something like this comes up and they select that. That's what they used for their charge code on the claim submission. So we did good there. So we can look at these things all the time, and we do. And we just page through them, and so here's this one, something happened, but here's one. It's really, I don't know where I can find it. It's actually it's a little comical. It was like one word. It was like hernia. I don't think they understood what keyword and context and the whole semantic enrichment and making proximity and all that kind of stuff. They just put one word in. So I don't think they got it. And by the way, one word, I don't know if it's in this one, but we have reams and reams of this stuff, and just looking at it, this is okay. Okay, so this is how we make it better, and it really is nice. And this is one of the things when we talk to customers. I had a customer today we're talking to, potential customer. And he said, well, how do you handle E&M, which is called evaluation and management? I said, we need to build a whole, in evaluation and management is you come in and say, I need to talk to you about my elbow, and can we review the process, and whatever it is. Review is a kind of a kickoff word, evaluation of something, but you can't always depend on it. And then on top of that, they get paid based on how much time they spent with you talking about your bad elbow. So, and I said, well, I said to the person under the phone, I said, when was the last time you saw an encounter note that said, I spent 15 minutes with the patient discussing their elbow? They don't put that down. They talk about the arthritis and all kinds of stuff. So we're now looking through how we figure out a little bit better to do the evaluation and management because they get paid on it. That's the key. All right, now here's the home stretch, guys. Home stretch. This is all right. So now let's take. All right. So we've just gone through the prototype development, and we're going to beta. As of today, actually, we've now defined it basically. We're going up with a company called Athena. Athena Health is probably the number four provider of electronic medical records in this country. Number two is called Allscripts. We're with them also. So we have got our technology in two of the big boys. So let's take this one. This is a current one. So this is fun because we did some neat things on this one. So it's branded IntegraCoder. Again, you're going to see our technologies in there. And so here's IntegraCoder. Let's see. All right. So what happens is it comes up, and you know again this is what really happens. They're looking for. We have to disguise the innocent. So you load up, and again, so we get the little IntegraCoder, man. That's okay. One of the developers got to kick it. But here we go. What do you see? Text. Boom, right there. Now, it's interesting because Athena Health, they don't call them ICD-9. They don't call them diagnoses. They call them problems. So we had to, we changed a couple of things. So they don't like to refer to them as anything but problems. So this is a 17-year-old that was playing basketball. So you saw there's the exact same results, but here, I mean, this is our technology here. You pull up, you take out of here, you look at the procedures. It could be a bunch of, now one of the things is a neat feature that we put in here is you can actually, they'll give you a definition. Again, the customer, all this stuff is in the database. It's just that the customer said, well, can you, if this is a biller or this is an administrator, can you tell them what an open, whatever that is, open treatment of distal, some of the definitions are decent, they come up and tell you what it is. So just an added feature. They also have a feature where if you want to look and find out if there's anything else that you might be able to bill for, it'll actually take you into, we call it the book view. And I said, why do we have to call it that? Why can't we call it database view? And they said, no, because everybody knows it's the book. So you can actually pick any one of these and add it to your encounter. So you can add that, whatever. So I'll go back here. But so the other thing, so what happens is, and we're finding out that the results of our technology, taking and producing relevant suggestions, it's actually made as I said, the provider is starting now to pay attention to what they're writing, number one. And number two, the providers really never saw, in big practices. Now in small practices, the provider will sometimes code. But in big practices, the provider, they heard about codes, I don't code. I don't do Windows and I don't code. But they're being exposed now to saying, oh, shoot, man, that's a 2780. And people get excited about that because when you do this, you go up here and you say the dashboard view, that's big time. That's pretty good money. So the reason it's called an RVU, what happens is if we had put a zip code in here, the zip code drives what they get paid. A heart stent in New York is charged at a much different rate than a heart stent in Albuquerque. So every region has their own code of what they call RVU. It's called relative value unit. And this drives the money. And I'll tell you what, docs get paid on RVUs. That's what they get paid on. So the doc may say, geez, I wonder, you know, and it's someone they have memorized, but if you're in a general practice or you're in like a cardiology where you can see a lot of different things, the guy might say, well, geez, you know, what can I get paid for that? It's not that this, but they actually, no, it's the wrong one, sorry. Dashboard. So you can do that one, that's 0.78, that's about $40. No, but in any case, so now I'll tell you what happens now. So up in here, you got the procedures, these are the different services, you know, I have to have a split, this guy. So we go back here, so up in here, sometimes you don't see the doctor until the end, because it may be the person at the front desk saying, what's your problem? You may have a practitioner say, give me a little bit of information. A lot of times they just talk into a thing, and so this populates here, and the provider may see you at the end. If they click on this, they can then see what's going on. So this really is the whole beginning of the encounter. Now what happens is, this is where it gets serious down here, because what you're doing now is you're starting to say, okay, they came in with a joint pain ankle and they came in with a fractured foot, okay? So this is what is, they've assessed that at. Then they say, well, we have, no, I have no clue. I'm not a coder, never will be, because I'm not very good at that stuff, but what happens is, I just put the stuff in there just for kicks, for hoops. So what happens then is, you then begin to build the case for what you're going to charge for. So what will happen here is, you come down here and they have these things called modifiers. Well, this is where it really gets serious, where you got to look up here and say, okay, you got to have a modifier, and that tells what that modifier is all about. So if you don't put a modifier, you're not going to get paid. So they would add that modifier. They'd add a diagnosis here. This is fun. This is working great. I love it. Let's look at see if we have any modifiers here. We go. That's a cool one. I have no idea. I gave a talk today at noontime, and one of the people on the call was a coder. She had like 4 or 5 of these acronyms after her name and it was like, you know, CCPA, whatever it was, you know. And I said, look, and her name was Alex. I said, Alex, I apologize. I said, this must be like chalk on a blackboard. She said, no, it's kind of humorous. She said, I don't think anybody would pick those codes together. And I said, well, because what happens then? So you come down here, and again, the objective here is to get something that will be accepted. And so what we have now is, now we've added this, where you actually scrub it, and it'll come down here and they'll say, okay, you guys, well, geez, I got lucky. I got lucky because I'm starting to learn how to do this thing. So what happens is, these are fine. They turn green, home free. You know, you're fine. Let's submit. Anything that's green, bingo, right there. But then it'll tell you, it'll come up here, and the way it works, and again, remember, everything comes from what was selected up here. Comes down, and then what happens is, you do, right here, it says, procedure should not be billed in office. Okay, so, yeah, you can't fix a fractured leg in the office. I guess you got to go someplace else. So it'll tell you, because then what happens is, what you need to do is you need to get all green down here if you're going to charge for it, because then what happens is you hit this and it goes off to our partners. Our partners they populate a claim form, they scrub that and they send it out. And if it's got a bunch of stuff going on down here bad, it's going to get rejected. So, and then this is the ROI part of our business here, where in fact what you look at is 3 things. You got claims backed up. So you'll have a practice where they see 100, 200 patients a day, you know, maybe 10 docs, and all of a sudden they start to build up. And those claims that haven't been submitted, coded, billed, and submitted, that's cash. So they have a cash flow problem. So they need to be able to do that quicker. This helps them. Then the other thing that happens is, if you submit the wrong, you don't get your good scrub down here, and you don't get a lot of good green, it will get rejected. And then that goes into a 90-day cycle. Again, you're not getting money. The third thing, and this is bad, you get enough rejections or denials, you're going to get audited, and nobody wants to get audited. So it's a real neat tool for what we call the backroom part of the business, but it's also really neat for the front part of the business. So pretty cool. So what you're seeing here, you're seeing MAI, rule base, all in action in a business, in an industry or a market space. Well, we knew it was going to work, didn't we, Margie? We looked at this thing, we said, you know, I think one of my talks was, I said, this is a perfect storm. They got text coming in here, they got a big old vocabulary that they got to control, and then they got the Affordable Care Act, and they got this penalty, that penalty, so chaos works.